In this episode of the Nurse Practitioner Podcast, Dr. Margaret Fitzgerald discusses measles, including the recent outbreaks, vaccination, complications, and more. Thank you for taking the time to talk with us today.
Oh, I'm so happy to be doing this as a nurse practitioner whose practice has been exclusively in federally qualified health centers. I do take my role as a public health officer, if you will, very seriously.
We've all been hearing about the recent outbreaks of measles, also known as rubeola. As of late May in the U.S., there have been more than 1,000 cases of measles across 30 states and 3 confirmed deaths in 2025 alone. According to the CDC, the majority of these cases have been linked to 14 measles outbreaks. Could you please tell us about what defines an outbreak and some of the contributing factors for the recent outbreaks?
Well, there is a scientific definition of an outbreak, and it's 3 or more cases that can be tracked to one another. In other words, the first person in a community shows up with measles, and then 2 other people had contact with that individual, and now you've got 3 people with measles, and then it just takes off from there. What has contributed to this outbreak? Well, overall, there has been a rise in measles cases globally. And measles has been reported in every continent in the world, save for Antarctica. And we are a global village, if you will, and people do travel about. So what has caused the rise in measles globally? Part of this is reduced immunization rates. And then how does most measles virus end up coming into the United States? The beginning of an outbreak is almost always traced to a person traveling outside the United States. And as I said, every continent except for Antarctica, so it can be European nations, Asian nations, wherever, and then it's brought in, and that's how an outbreak gets going.
Thank you for that information. Next, what is the mode of transmission of measles and how contagious is the disease?
This is respiratory droplet transmitted for the most part. So think cough, sneeze, something along those lines. And measles is actually one of the most contagious viruses known to humankind. It is estimated to be at least twice as contagious as the Omicron variant of COVID-19. And it is at least 6 times as contagious as influenza A and influenza B. So this is a pretty nasty little virus here. The other part, when there's an outbreak in your community or around your community, you might hear of something along the lines like if you were in a given place. I'm going to give you a quick example from around Washington, D.C. at Dulles Airport, that there was somebody who had entered the United States not knowing they had measles, but they were in the contagion time of having measles. And that the Dulles Airport, which is in Virginia, outside of DC, and what the Virginia Department of Public Health announced was anybody who had been at Dulles Airport in certain places, baggage claim, transport, between a period of 4 to 9 p.m. on a Wednesday in Terminal A, and in baggage claim from a period of time of about 4 hours a little bit later. So why is it that they're telling people if you were simply in Terminal A or you were in baggage claim during this window of approximately 8 hours in total, why are they warning people about such a big period of time like that? Well, part of it is because this is a virus that can hang around in the air for an inordinate period of time. And therefore, there's even a risk of contagion if you were not in the same airspace at the same time as the person with measles. So to compare that to like the common cold, the rhinovirus, I have a cold. I am being very rude and not covering my cough or sneeze. I cough or sneeze in your face, tag you're it. You're going to come down with my cold. But you and I would have had to have been pretty much in the same airspace for you to catch my cold. You don't have to be in the same airspace at the same time as the person with measles to pick up measles from another human being.
Thank you for explaining that. Which groups have been most affected by the recent measles outbreaks?
Well, when we look at the number of cases, or when you look at the overall epidemiology of the cases of people with measles, and I've been following these numbers for many, many months now. First of all, 95% of them are unvaccinated or unknown status. Vaccinated has been about 3%, and with one dose of the MMR vaccine, the measles, mumps, and rubella vaccine, 2 doses of the vaccine considered to be fully protected, as protected as we can be off the MMR vaccine, about 95% protection, has been about 2%. And so the majority of people who have come down with measles are either unvaccinated or under-vaccinated, because the reason we give a second MMR is to improve measles protection. How about age range? Under age 5 has been roughly 1/3 of the people who have come down with measles. So in other words, younger kids. Ages 5 to 19, about roughly half of the cases. Ages 20 plus has been about 20% of the cases. And then age unknown has been a really small percentage, like about 1%. So what we're seeing is this is really hitting the younger kids, and then also all the way up to the teen years. So one way of looking at this is in the United States right now, the vast majority of people coming down with measles will be kids. And these are children who have been unimmunized for the most part by parental choice.
Speaking of vaccination, what are the routine measles vaccination recommendations for children, and for how long does it provide protection?
Well, let's just talk about the measles vaccine overall. One thing that we notice is with vaccines is that there are vaccines where it's recommended we get repeated doses, like COVID-19, the influenza virus. So why is it we're recommended to getting a lot of those vaccines? That's because those are mutating viruses or viruses that come up with new strains, okay? The measles virus, the protection we get from that is part of the MMR, measles, mumps, rubella vaccine. And you do the series under ordinary circumstances, you're done for a lifetime. And the reason is non-mutating viruses. Typically, the first measles MMR is given around age 1, somewhere around 12 to 15 months when kids come in for a well child visit. And then the second dose is given at age 4 to 6, more typically at age 4. And the reason for that second MMR, as I mentioned before, is because there is about a 5% likelihood that one MMR will not provide that long-term measles protection. And therefore, we give a second dose to get up to the 95% protection. And let me just make one other comment. The measles virus is so darn contagious that what you need to do is to have 95% of the population immune to measles, either via having had the disease or full immunization, in order to squelch an outbreak in your community. 95%. That is about as high as any virus around. With mumps, you need 80% of the population protected to exploit that herd or community immunity. But this virus is so contagious that you need 95% of the community immune to squelch an outbreak.
Do the vaccination recommendations differ for infants or children living in the U.S. who will be traveling internationally?
Oh, thank you for bringing that up. This is something very important. One of the most important conduits into the United States of the measles virus is actually children under the age of 1 year because they're not immunized. And these might be kids whose parents are planning on getting them MMR immunized. But let's say that the baby is 7 months old and the family wants to travel to wherever, where the family has roots, or they simply want to go on a vacation. And so there has been a recommendation for well more than 10 years from the CDC. It might be even as long as 15 plus years, that infants between the ages of 6 to 12 months traveling outside the United States, regardless of the destination, should get a dose of MMR, ideally 28 days before they leave the country. And that's to provide the measles protection. So not only are we keeping the measles virus from being brought into the United States, but also we're preventing this little one from becoming very ill. Because that's one thing to keep in mind. Measles is a rough disease. And kids are sick 10 days, 14 days with this, and they are sick with a capital S. So that's why there is that recommendation. Now, I will tell you, when you go to then give the typical MMR series, I recommend you check the CDC's recommendations on that to ensure the child is then fully immunized. By the way, for infants under 6 months, there is no recommendation for getting the MMR. In other words, we don't have the data on the efficacy of the vaccine in the children who are that young. Now, what about kids who are a little bit older? Like, let's say that you've got a 13-month-old who has not received MMR, but that child's going to travel outside the United States. There is a recommendation that that little one get the vaccine they would have gotten anyway at age 12 months, the MMR, plus a second dose in order to more fully protect them before the travel. So again, the child doesn't get sick and the little one doesn't import the virus to the United States or any place else.
Thank you for those insights. Let's talk about the clinical presentation of measles infections and complications. What are the classic signs and symptoms of measles, and how can providers recognize this illness?
Well, here's the interesting part with measles is that if a person with measles, and I'm just going to say a kid with measles because most of what we're seeing, they are in fact kids. If a kid with measles came in covered head to toe with the dense maculopapular rash that's usually seen with measles, we would be like, okay, boom, we've got it. We've made our diagnosis. But herein lies the rub. The classic presentation of the measles is the 3 C's. C number 1, cough, usually starts off dry. C number 2, coryza, clear nasal discharge. And C number 3, conjunctivitis with watery, not purulent discharge. Now, I've been privileged to see kids in my practice now for my entire career as an NP, which is well more than 35 years now. And you listening to this and you're going, really? Cough, runny nose, and conjunctivitis? Does that not describe about 50% of the sick visits that we see with kids? You're right. It starts off looking like kind of the common cold. But those of us who see kids in our practice know something. Kids can present miserable, where let's just say this is a child who has a good old-fashioned rhinovirus upper URI, and it's a toddler. So it's like an 18-month-old. And the kid feels rotten and probably the throat's a little sore and they've got this cough that might actually even scare them, and they're producing their body weight and clear nasal discharge, and their eyes are watery, and they're clinging onto the parent, and they're fussy, and they're just miserable. But they're not that sick. They're not that sick. The kids presenting with measles are sick. So they present for 2 to 3 days with the classic 3 C's. They also develop what's often called the 100-mile stare, where these kids are just like staring off into space because they feel so miserable. And what I would encourage you all to do is to just get on some search engine, type in clinical presentation of the 3 C's in measles, and you're going to come up with a whole bunch of images. And they're usually, quite frankly, old photos because we just don't see that much measles now. But you'll get what I mean by this 100-mile stare. Now, so that's the super non-specific presentation of measles, where it looks like the poor little one just has a really, really bad cold. However, there is something else we can look for, and that's Koplik spots. And Koplik spots are pathognomonic for rubeola or measles. In other words, this is the only time you'll see Koplik spots. They appear about 2 days prior to the onset of the rash on the oral mucosa, and they're described as looking like grains of salt on a wet background. Personally, I don't think that's how they look, but that's when you come across that in the literature over and over and over again. But one more time, just spend a minute on a search engine, pop in Koplik spots, which is spelled Koplik, Koplik spots, and you can investigate the oral mucosa. There. Now, herein lies the rub. Not everybody with measles will develop Koplik spots, but about 2/3 will. About 2/3 will. So it's a great rule in, but the absence of Koplik spots, particularly if you know you are residing or practicing someplace where there's been an ongoing rubeola outbreak, it's really, really helpful to take a look at that. But don't rule out measles just because there aren't Koplik spots. So what about the rash, the characteristic maculopapular rash that is seen with measles? It usually starts at the hairline as small raised lesions or flat spots, spreads from the head to the rest of the body. Usually by the time the person is at the skin rash manifestation, they're having fever spikes to 104, 105. Couple of other things to remember. This rash often coalesces to a generalized erythema, and the rash is usually fairly easy to see in a person with a lighter skin tone. It might be a little bit more difficult to see in a person with a darker skin tone. So one thing I would encourage the clinician to do is, particularly with people with kids you suspect have measles who have a darker skin tone, really, really inspect the skin very, very closely before you deem they don't have any skin lesions, and then run your fingers over the skin. Because since it's a maculopapular rash, some of the lesions will be raised. And oftentimes, if this is a child old enough to complain of a sore throat, they'll say, when you ask them if they've got a sore throat, they'll tell you they've got a little bit of a sore throat, but there'll be no exudate. So it doesn't look like the throat of a kid with a strep pharyngitis or a mono or something along those lines. You asked about complications. First of all, remember, another colloquial name for measles, commonly used when it was endemic in the population, was 10-day measles. And the reason it was called 10 days measles is that rubella, aka German measles, was often referred to as the 3-day measles. And really the only overlap between these two diseases was the skin lesions, because rubella or German measles, it's 3 days long, little achy, a little itch, one and done. You have it, you never get it again in your life. You're covered against it by the R in the MMR. So why do we bother immunizing against rubella if it doesn't kill people? Because it's one of the most teratogenic viruses known to humankind. Therefore, we don't want it in our population because we don't want people during pregnancy contracting rubella. But Rubella was called the 3-day measles because that's how long it lasted. Measles was called the 10-day measles. Gives you an idea of how long these kids are sick. So anyway, back to complications. About 1/3 will have a complication. Pneumonia will be the most common complication. It's also the most common reasons for measles death in children under the age of 5. I do know out of the 2 children in the United States who have passed with measles complications that I did some reading and I heard the parents being interviewed. The first child to die, it appears as if she did pass from a measles-related pneumonia, might have been a component of encephalitis as well. But pneumonia will be the most common reasons for measles death in kids under the age of 5. And overall, it accounts for 2/3 of all measles-related deaths. And on chest x-ray, there'll be mixed reticular opacities, airspace consolidation, and lymph node enlargement in the hilum. So what bugs are we talking about that could cause the measles-related pneumonia? Likely it is from the rubeola virus itself. It's the measles virus itself, so it's a viral pneumonia. And then if there is a bacterial superinfection, the most common organism will be Streptococcus pneumoniae, aka the pneumococcal organism. And one thing to consider is that if, let's say that you're dealing with a 3-year-old who's unimmunized against MMR, and this child came down with measles, there's a high likelihood then the child has probably also not received pneumococcal conjugate vaccine and to protect against invasive pneumococcal disease. So that needs to be kept in mind with their care. General rule, the measles-related pneumonia will kick in around day 7+ of the illness. And when you compare that to like influenza, if a otherwise healthy child has unfortunately contracted the flu and they've been pretty sick with the flu, general rule by day 4, 5, they've really turned a corner. And what you will see is around day 7 with measles, the child is still pretty sick and then gets sicker. They have more difficulty breathing. Now, the onset of measles-related pneumonia can be as soon as day 4, but general rule, it's going to be day 7+. So there needs to be a way of kids or anyone who's been diagnosed with measles is to have good follow-up with them to make sure that they are not getting worse. Another complication, and this is absolutely heartbreaking, is encephalitis. Encephalitis, as we all know, it is a brain infection, brain swelling. This onset is also around day 7 to 10 of the illness, where now there is a new onset of headache, fever, confusion, and sometimes seizures. It's 1 person in 1,000 of cases of measles, usually a child, and there's a risk of permanent developmental disability, vision and hearing loss, and the overall mortality is about 10 to 20%. And many of us are familiar with the books that were written by the great British author Roald Dahl. He introduced us to Willy Wonka in the book Charlie and the Chocolate Factory, James and the Giant Peach and all. And he and his wife, who lost her child in the 1960s to measles-related encephalitis. And the thing was, this was in the very early 1960s before there was an MMR vaccine. And just bear with me for a moment of what a quote he said once the vaccine was available, because he was encouraging parents to get the vaccine for their children. But he had gone to the child's bedroom where the child was recovering from measles, and he was actually starting to feel better. He described her as well on the road to recovery. And I think they had 5 kids. And back then, not to minimize measles, but everybody got it. And so he knew what a kid with measles looked like. and he was going over how to make little animals out of pipe cleaners. And when it came to her turn to make one herself, I noticed her fingers and her mind were not working together and she couldn't do anything. I asked, "Do you feel all right?" And she said, "I feel all sleepy." And in 1 hour, she was unconscious. In 12 hours, she was dead. That is what the encephalitis can look like. An MMR vaccine can prevent that kind of heartbreaking death. And that was 1962, and it was in England where the child died.
Could you talk about populations at high risk to develop severe disease or complications?
Let's divide this into two categories. One is who's at greatest risk for contracting measles, and then who's at greatest risk for getting very sick with measles. So who's at highest risk for measles acquisition? It makes sense. Unvaccinated children or adults, and then incompletely vaccinated individuals, the person who got that one MMR but not two. Individuals with known exposure to measles or recent travel to areas with active measles transmission. I just have to say it one more time. Every continent in the world except for Antarctica, and no one lives in Antarctica except for some scientists. And then people with immunocompromise, such as from cancer, chemotherapy, HIV infection, and use of select medications like the immunomodulators, biologics, and things along those lines. So those are the people most likely to get measles. Who's at highest risk for severe measles infection and or measles complication? Infants, kids under the age of 5. Worldwide, you're going to find the majority of deaths from measles will be in kids under the age of 5. But interestingly, adults over the age of 20. So it's not even like adults over the age of 65 who might come down with measles. It is adults over the age of 20. So they can really get very ill with measles during pregnancy. In 1,000 years, I'm never going to say that pregnancy is an immunocompromising condition, but it is a slightly immuno-altering condition. And we know that measles, influenza, COVID-19, the list goes on, of women during pregnancy who contract those get much sicker than their age match controls who are not pregnant. And then when they've got a compromised immune system from cancer, chemotherapy, HIV, the select meds that I had mentioned before.
Thank you. That's important information. What testing is recommended if measles is suspected?
Well, first of all, if you even have a suspected case of measles in your community, what you want to do is make sure that you are in touch with your local Department of Public Health, because obviously we're looking to contain any kind of spread of the illness. And so what can you do for testing? There are a number of different ways of testing. What will likely happen is that your Department of Public Health will point you to the type of test that they can most easily turn the results around. So there are different ways of doing this. One of them is Rubiola IgM. That's a serologic test. So in other words, a blood draw. And then there is some nasopharyngeal testing and some urine testing that can also be done. And one more time, just to say, notify your Department of Public Health for additional information on available diagnostics. And the question often comes up, because most of the time, let's face it, we're talking about kids with measles. Do you need parental permission to notify DPH? And no, because this is a notifiable disease to the Department of Public Health, because there is a greater good need to have an aggregated bunch of information on people in the community who actually do have rubiola. And I also want you to keep in mind, whereas we're at a point right now with the current rubeola outbreak in the United States, of saying we've got more than 1,000 confirmed cases, et cetera. FYI, 2 months ago, we had 300 confirmed cases. So we've tripled in 2 months, tripled plus in 2 months. Keep in mind, there are likely a lot of people who've had rubeola who are not coming forward to be tested for it. They're not. So that 1,000 number, particularly in a community, is one particular county in one particular state that the rubeola outbreak has been particularly severe. There are likely literally hundreds of people who have had rubeola there, but have not come forward for care. And therefore, they're not being counted in these confirmed cases.
How should providers manage cases of measles? Are there any treatments?
There are treatments. Let me go over a few things here. First of all, there is no measles specific antiviral. Like we've got COVID-19 specific antivirals. We've got influenza specific antivirals. Okay. We do not have a rubeola specific antiviral. Few things that have come up, and you might have had a patient say this to you. Can I have a prescription for vitamin A to prevent measles? Well, first of all, I will say baseline, good, healthy diet, lots of fruits and vegetables. You know the drill. That's a good place to start in keeping your immune system healthy so it fights off any kind of a virus. Or if you pick up a virus, it minimizes how severe it is. But vitamin A plays no role in the prevention of measles. And unfortunately, some well-meaning parents and caregivers have been given high-dose vitamin A to kids in areas where there's been rubeola outbreaks in an attempt to minimize the risk of getting measles. And what the kids are ending up with is vitamin A toxicity. So we don't want to be doing that. However, what if you have confirmed measles and there is evidence of possibly shortening the disease duration because vitamin A is an immune modulator and minimizing the risk of severe disease? In the person with measles who presents with severe disease, there's about a 50% reduction in death rates with vitamin A supplementation, reduced pneumonia risk, and reduced risk of eye damage and subsequent blindness. And what I'm going to do is refer you to the American Academy of Pediatrics website, and they will give you the doses on that for the vitamin A, because it is a really, really big dose. And the dose varies. If the child's under 6 months, they get one particular dose and they get it once a day for 2 days. Remember, this is a vitamin that hangs around for a long time. There's another dose for kids 6 to 12 months. Again, it's just once a day for 2 days. Over the age of 12 months, yet another dose. And that would be if it was a 35-year-old with measles. It doesn't matter. It goes all the way through the adult years. It can be given orally or parenterally. It's generic, it's inexpensive, and not so much in this country, but in certain parts of the world, there is a fair amount of vitamin A deficiency. And if there is documented or suspected vitamin A deficiency, then a third dose is given. The general thought is, in this country, the third dose is usually not needed. You might also have heard that there have been comments that, well, you can treat measles with an antibiotic. You can treat select complications of measles with an antibiotic. Okay. There is a documented or suspected bacterial superinfection on top of the viral pneumonia from rubeola. Yes, of course, you would go ahead and treat with an antimicrobial, an antibacterial. Otitis media is a fairly common complication of measles. You would go ahead and treat with an antibacterial at that point.
What are the recommendations regarding post-exposure prophylaxis for measles?
Oh, thank you for asking that because, of course, what we want to do, if at all possible, is prevent more people in a given community from contracting rubeola or measles. So if the person was measles exposed and there's no reliable evidence of rubeola immunity, i.e., was never immunized or no vaccine documented, within 72 hours of the exposure, you can offer the MMR. And there's quite good evidence that that will kick in fairly quickly because this is a virus with a relatively long incubation time and either prevent coming down with the rubeola or really minimize the severity of the disease. If you're 6 days out from exposure, immune globulin can also be offered. And one more time, if you're wondering, how am I going to get my hands on all this extra MMR vaccine or the immune globulin, your Department of Public Health is going to be your really, really, really good source on that one. I also want to remind you of the following. Even if the person post-exposure who is non-immune or unimmunized, even if that person came in, got the MMR vaccine, got the immune globulin, whatever it was, they will still be required, likely by public health, to do community-based isolation, i.e. stay at home, for one or more incubation period, 7 to 21 days post-exposure. And the reason for that is they don't want these folks walking around and spreading the virus if they are in fact incubating it.
Finally, do you have any advice for NPs in correcting patients or caregivers' measles vaccination misconceptions or in addressing vaccine hesitancy?
Working with families, caregivers of younger children who are vaccine hesitant, or for that matter, the adults who are hesitant themselves, I would call it a really nuanced dance. And part of this is, I believe most of us are firmly based in scientific evidence. And so, I can look at these data and go, okay, this is what I've done for my family. I have grandchildren. All my grandchildren are fully immunized. So my offspring carries this as well, although none of them are in healthcare. So what if you do have a family, though, that says, yes, but this is what I've heard. Yes, but this is what I've read. Well, there will be a percentage of the population that is unmoved by scientific evidence. And in fact, there was one study done that looked at vaccine hesitant parents that were given standard of care, if you will. And standard of care was kind of like, yep, your baby's 12 months old, they're due for an MMR and a few other vaccines today. Go down the hall, you'll get the shot. They can get their shots. In other words, just like standard of care. And another group that was given written materials, verbal materials on vaccine safety. It was pretty in-depth education program. And what was found was the folks that were given the more in-depth education were more against immunizing their children at the end of the program than they were at the beginning. So it really had a quite counter effect than was thought. So what actually works? In patients who are vaccine hesitant, but could be encouraged one way or another, is one way of putting it is not to say, your child's due for these shots, go down the hall, you'll get them, okay? And this is what I do. This is what I do. And I can really see in my own practice, it has turned the tide on flu and COVID vaccines. And let me just say, I'm privileged to work in a community that views vaccines as a very good thing for the most part. And what I will say is something like great news, and I'll limit my comments now to measles. Great news. We've got plenty of the MMR vaccine. Your child is due to get this today. And you know what it's going to do? We're going to give the little one a shot now at age 1. We'll repeat it at age 4. And you know what? It's going to provide them great protection against measles. You've heard about the measles outbreak in this country. Yes, isn't it frightening to think about that? This is a really contagious virus. I'm so glad we can help you protect your child. And what you'll notice is all of that is positive message about the vaccine. Now, on the other hand, if the parents go, no, I will support that family. I will support that family and say, tell me what your concerns are. And then we'll have more of a dialogue. And then what's another thing that tends to work really well is personal stories. And I can tell personal story about one branch of my family where my grandchildren reside in a community where a lot of the kids are not immunized by parental choice. My grandchildren are immunized. They're fully immunized. And I can give them examples and I'll say, okay, I hear you. And this is your child. I hear you. My own grandchildren are all immunized. All 7 of them are fully immunized. And one part of my family resides in a community where lots of kids aren't immunized. And my grandchildren didn't come down with measles when so many of the other kids in their school did. My grandchildren didn't get chicken pox when so many of the other kids do. So not everybody is going to have a story that they can personalize that much, but those types of stories will move the needle on immunization. And then there will be some people who opt not to immunize their children. It's interesting. I have a number of nurse practitioner colleagues who practice in college health. And a lot of these kids that weren't immunized in childhood, now that they're 18 plus and they can advocate for their own health, they're coming in and getting immunized, which is interesting. In other words, they have formed their own thoughts on immunizations, even if their family were not thinking along those lines.
Dr. Fitzgerald, thank you so much for taking the time to share this important information with us.
And thank you, Kimberly. This has been a great honor to speak with you today. It's also been a lot of fun. And I hope what we hear is that the rubeola numbers start to go down in this country and that we are able to protect the patients that we've been entrusted to care for.
For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, and much more. Please leave us a 5-star review on iTunes and Spotify, as it helps with the podcast's visibility and helps us to keep bringing you this great content. Also, don't forget to follow us on Facebook, Instagram, and LinkedIn at The Nurse Practitioner Journal and on X at TNPJ_journal. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed on this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Wolters Kluwer. Thanks for listening.